Hello and welcome to our Facebook Live, In a Nutshell, HIPEC and Ovarian Cancer. I'm Maggie Nicholas Alexander, the Senior Director of Gynecologic Cancer Patient Support and Education at SHARE. Before the program begins, I'd like to tell you a little bit about SHARE. We're a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with breast or gynecologic cancer and provides outreach to the general public about signs and symptoms. For more information about upcoming webinars, support groups, and our support lines, please visit our website at sharecancersupport.org. Now, I'd like to hand it over to our guest today, Dr. Han, who we're so excited to have here today. If you wouldn't mind introducing yourself before we dive into our discussion.
Yes. Hi, Maggie. Thank you so much. It's really a privilege and an honor to be here with everybody. As you said, my name is Ernest Han, and I'm a gynecologic oncologist at City of Hope. For those that don't know where City of Hope is, it's located in Duarte, California, just outside of Los Angeles. And yes, I'm someone who treats patients with gynecologic cancers, and pleasure to be here.
Great, thank you. All right, so let's dive right in. Since we're talking about HIPEC today, let's start with first and foremost, what is HIPEC and how does it work?
Yes. So HIPEC basically stands for hyperthermic intraperitoneal chemotherapy. And it's a kind of a medical terminology for saying it's heated or hyperthermic, which is essentially heat. And when we talk about heat, we're talking something that is pretty hot. We're talking treatments that go from 41 to 42 degrees centigrade. So, of course, we don't work in centigrade in the US. And so that amounts to about like 105 to 107 degrees Fahrenheit. So it's pretty hot. And then the last part, chemotherapy. So it's the heated part of the we're heating chemotherapy. And the chemotherapy we use for ovarian cancer, it's like one of the more common and one of the strongest ones that we have, which is usually cisplatin. And then intraperitoneal. So that means we're delivering this hot chemotherapy right inside the abdominal cavity. There's been a lot of science to this HIPEC, and I will say that studies have shown that the effect of this heated chemotherapy is that it helps induce the cancer cells to die. We call it apoptosis. It may do it through different kinds of mechanisms. So one may be that it helps to actually increase the immune cells and the immune pathways, and also it might affect the cell's ability to actually repair its DNA that gets damaged from the chemotherapy and such. So making, again, these treatments more potent against the cancer cells and helping them to essentially die. So it's a technology that is very exciting. I know it's been around for a while, but has been more recently gaining traction, I think, for ovarian cancers.
Great, thank you for that. And so when can HIPEC be considered for ovarian cancer?
Yeah, so that's a great question. So, HIPEC basically, we use these technologies based on, clinical trials and, scientific evidence. And so if I'm seeing a patient and a patient asks me, am I a candidate for HIPEC? The things that we look out for is that ovarian cancer, we treat primarily the most common one being high-grade serous ovarian cancer. It's just kind of a specific type of ovarian cancer, probably the most common type. And those are patients that, we typically look out for. And also patients who have advanced cancer. So unfortunately, I know that ovarian cancer, most patients do get diagnosed in advanced stages. And so HIPEC could be something we use in those type of patients, but particularly it has been maybe more helpful for patients when the cancer is more confined within the cavity of the abdomen and the pelvis, and not like, let's say, spread to the lungs or somewhere outside. It's not someone like someone who has early ovarian cancer. There hasn't been really studies, supporting that use in that group. And then lastly, I would say that the other things that we look at, so not only is the kind of ovarian cancer and the stage of cancer, but we also look at their treatment. So if a patient comes to me newly diagnosed, a lot of times we have to decide on how we manage. And kind of two different ways we've been looking at it. One is sometimes we find that patients we may be eligible for doing surgery first and then chemotherapy. And then we do find another group of women where we feel that chemotherapy first might be beneficial for a few cycles, and then we do surgery. And that's the group of patients that we might be able to then use HIPEC and at that time, and then follow that with some more chemotherapy afterwards. So it's really that specific pathway of patients that we've been targeting for potential HIPEC use.
Great. And can you discuss the potential benefits and risks of HIPEC as a treatment for ovarian cancer?
Yes, absolutely. So I will say that based on several clinical studies now, it appears that HIPEC is relatively safe to add to patients undergoing surgery. I think when I counsel a patient who is looking for the use of HIPEC, I will tell them that basically you'll still have very similar risks that you have when you go through a major big surgery to remove all the cancers out. And those risks can be things like, bleeding, can be risk of infection, these kinds of things. And adding the HIPEC to the surgery may add just a little bit more risk, to that. I mean, you are actually getting chemotherapy at that time, so there can be sometimes more nausea and some of the more specific chemo effects. We did at the beginning see some more problems affecting the kidneys, with the HIPEC, but some of the trials then have used other drugs and methods to actually counter that effect. And early on, we saw some issues in the kidney, but now we're not really seeing that at all with this added treatment to the HIPEC. So I do think that now, it's certainly better, and we're learning method wise how to make this as best as possible. So I don't think that again the risks are that much greater, I would say, in these situations. But again, it's something to talk to with your oncologist. So
And then just the benefits as well.
yes, absolutely the benefits. So yeah, with HIPEC, we do oftentimes discuss this study that was done in the Netherlands, and they took a group of women who did the chemotherapy at the very beginning of their diagnosis of ovarian cancer, and then they took them to surgery, and they were then randomized to two different groups. One group that got actually the heated chemo, and then the other group who did not. And then they continued with a few more afterwards, cycles of chemo. This study actually, it was a randomized study, so it's one of our best type of studies you could do to avoid some of the biases. And the study found that patients who got the HIPEC actually lived 12 months on average, about 12 months longer than the women who didn't get the HIPEC. And so it's actually pretty exciting. It's something when you can see a significant benefit, for women living longer. It's always, I think, a big plus.
And I think that's a good segue to my next question, which is okay, well, given that, then why is there a controversy surrounding the use of HIPEC for ovarian cancer?
Yeah, so that I think that's a really great question, and it's yeah, you would be kind of thinking, well, if I can do better with this study, why not? Why is not every woman getting this? And I think there's a lot of different factors, when we think about why that happens. First is that, I explained that this was like one of the best type of studies you could do. But you also, when you look, zoom down into the study and you look in more details, some people in the community, some of the doctors have looked at it and said, well, you know what, you did this great study, but the treatment arms that you're using and the kind of treatments that you're using are a little bit more outdated than what we do now. And to some degree, it is true because these studies are difficult studies. And they accrue a lot of women, and it takes, and this study took about over 10 years, to complete the study. So, and there's a lot of clinical trials going out there, and we continuously get advances, and we continue to use those advances to help our patients. And you can imagine if you started this study 10 years ago, and then 10 years have gone by, or at least even 5 years have gone by, we're discovering new drugs, we're discovering different things. And of course, in this particular era, there was now the use of what we call PARP inhibitors or PARP inhibitors. Uh, these have been very exciting new drugs that a lot of our gynecologic oncologists use for patients, and some of those benefits, that are out there. Again, these drugs weren't specifically used in this study, and so some people maybe have argued, well, maybe I could have had similar benefits if I had used the PARP inhibitors instead of the HIPEC, because you didn't use these other newer drugs. And so, there is some controversy about that. But we have to say, though, still, at least in this, when you compare the HIPEC versus no HIPEC, it's still, they're still seeing that benefit. Whether adding these newer drugs and other things is going to still be a question for all of us. Also, HIPEC, are these kinds of procedures are, they do have some expertise required for this. Not all centers do this. And so part of the reason why maybe not everyone does it is just because their center may not have the resources available to perform this, whether it's the equipment, whether it's the physician, the expertise, or the surrounding supportive team that is needed to help deliver this type of care. So I think that there are probably several reasons why it just hasn't been across the board in the US, being utilized.
Great, thank you for that. And then again, another important question for people to know is that given all that, what are the latest research findings on HIPEC and ovarian
Yeah.
cancer?
Yeah, so it's really amazing. So there's so much great research going on, not only in the US, but across the world right now, trying to answer questions more about HIPEC and its use and when you can use it. And I just briefly mentioned about this controversy about not using the latest and greatest medications. Well, in the US, there's an ongoing trial using the HIPEC, the same group of women, those same groups. The only difference, besides the randomizing of the HIPEC or not, is that they're going to get these PARP inhibitors, so that we can maybe help address to see if the benefit of HIPEC is still there when everybody's getting the newest and the best drugs. And so I think that will help to further support, or maybe question the use of HIPEC, depending on those results. More recently, there has been some clinical trials also supporting use maybe in different circumstances. So I just mentioned that we use it when women when they get diagnosed and get the chemo first and surgery. But what about the women on the other side who said, well, I'm going to have surgery first and then get chemo? Is there a benefit for using HIPEC in that setting? And so currently there's a ongoing clinical trial trying to answer that question, trying to seeing if the women going surgery first, whether you randomize them to HIPEC or not, seeing if there's any benefit. And our institution at City of Hope, of course, is participating in that for a worldwide trial. Very excited about that. And so, there might be different settings. Also, some patients might already have had, gone through their primary treatments and done well for a while, but unfortunately they recurred with their cancer. And in that setting, then can you use HIPEC? Because we get a lot of those questions. And there have been some clinical trials not showing the best of benefit there. But I will say that there's two recent publications in this. One study looked at women when they recurred. They started with chemotherapy, and then they got randomized, to doing, if there were surgery candidates, to doing surgery with or without the HIPEC. And that group of women found an additional 7 to 8 month survival benefit with HIPEC. So maybe in that setting where you get some chemo first and then can do surgery, maybe getting some HIPEC there might be helpful. The interesting thing is that the women who recurred, some women actually had surgery first and then got chemo. And then again, another study, when they looked at that group of women doing in the recurrent setting, the surgery first, randomized to the HIPEC, and then some chemo, they didn't see the same benefit in that. So basically, it's kind of interesting. So maybe what we're seeing the pattern is that for some reason, maybe the HIPEC works better if you get some chemo first for whatever reason. Like, and we don't know why that's the case, but it seems like some studies are now kind of, being more consistent and supporting this notion that maybe the patient needs that chemo first to do whatever it does to the cancer, and then do surgery and with the HIPEC in that setting. Now that's just kind of some, I think things that are being tossed around at least, and we don't know and understand that well. Of course, more studies will help us to try to answer some of those questions. But it is very interesting, and if that's the case, again, it could potentially change the way we actually approach patients with ovarian cancer.
Yeah, it's great. It sounds like there's a lot of research happening, which is great to hear. And so you've shared a lot of information on this topic. And so I think just in closing, if you could sort of sum it up or give your main takeaways for patients about this topic, what would those be?
Right. So, I mean, I hate to sound like the commercials, but definitely talk to your gynecologic oncologist to find out if HIPEC is right for you. Because again, as I mentioned, there are very specific situations. So definitely talk to your gynecologic oncologist and see whether it's appropriate to use it. I think that the science does support the use of HIPEC, but we're trying to still better understand, which specific set of patients and circumstances where it is appropriate to use. And so I think there are more studies that are coming, out, and we're so excited about that. I always encourage patients to participate in these clinical trials because this is how we do continue to advance our therapies and advance the best treatments for patients as best as we can. So, but it's an exciting area, and we're excited with these type of treatments. And again, definitely talk to your provider.
Great. Thank you for that. And thank you, Dr. Han, for such an informative program. We just covered a ton of ground on HIPEC in a short amount of time. So really appreciate that. And then to
Fantastic.
everyone viewing, check out Share's upcoming educational programs and support groups and follow us on social media. That concludes today's program. So thank you again, Dr. Han. We really
All right.
appreciate
Thank you.
you
Thank you
being
so
here and answering
much.
these questions.
You're welcome. Thank